Hello and welcome to the CSF Rheumatology Author Interview Podcast. My name is Professor Peter Nash from the Griffith University in beautiful downtown Brisbane. And today I'm joined by my good friend and colleague, Professor Kevin Winthrop from the Oregon Health and Science University. Welcome, Kevin, and thank you so much for giving up your time. I know you're very, very, very busy. We're discussing another one of your papers. You've been that busy. But first, I'd like to congratulate you on winning the gold medal by the Digital Health Awards last month. So how do you feel about being a gold medal winner? Next, it'll be the Olympics, Kevin.
Yeah, I wish it was the Sydney Games, but it sounds great. I'll wait for it in the mail, Peter. I'm sure it's been sent.
I'll wait for it as well. So today we're discussing an interesting publication and we're turning to a letter from your group recently published in the Annals of Rheumatic Diseases. And it looked at Tofacitinib in particular, and it looked at both serious infection and age-based incidence of infection. So let's just get a little bit of background. Can you fill us in on what the EMA did to the use of Tofa in Europe, which the FDA didn't do to Tofa in US?
Yeah, sometime last year, I think it was 2019 sometime, EMA got very worried about the fact that there was this post-marketing cardiovascular study that had a signal of increased mortality and VTE associated with higher doses of Tofa particularly, but also some signal with the 5 milligram dose. And in that same analysis, they had looked at serious infection rates, and they had noted them to be much higher in people greater than 65. So they had put out a warning at that time, suggesting that Tofa, I forget how it was worded, but I think it was Tofa be used as a quote unquote last resort in people who were elderly. And that was the nature of the warning, which prompted this analysis, which was really specifically to look at, what is the risk of serious infection in patients over age 65, and particularly relative to other compounds.
Okay, so can you just fill us a little bit in on that safety study, the A392-1133, because it's still recruiting, I think. It's not completely finished yet.
Yeah, I don't think I've seen any final analysis, so I believe it's still going. And it was a post-marketing commitment primarily to look at cardiovascular outcomes. And so patients recruited to it were patients with cardiovascular risk factors, and they're randomized to either Tofa 5 or Tofa 10 or a TNF blocker, depending on where you were in the world, is either etanercept or adalimumab. And since that interim analysis, I believe they stopped the 10 milligram dosage. So, further enrollment was restricted to 5 of Tofa versus the TNF comparator. And
can you give us a flavor of what the interim analysis showed? Do you have the data handy, just so we can get a feel for what the concern was?
Yeah, I kind of have it handy. Maybe it's in my head here. The issue around infection is what I just told you. They saw an increased incidence primarily in this older age group. And actually, I just pulled it up here. This announcement was November 15, 2019. And it said, quote unquote, available data also showed that the risk of serious infections and fatal infections was further increased in elderly patients above 65 years of age. Therefore, Tofa should only be considered in these patients if no suitable alternative treatment is available. So that was their statement around infection. What they saw data-wise was, some, dose-dependent increase in serious infections that were non-fatal as well as fatal. The serious infection rates were kind of like between 3.5 per 100 patient years for Tofa 10, down to, I don't know what that is, probably about 2.75 or something for the TNF comparator, and Tofa 5 was in between. It looked like it was about 3.3 or 4. So pretty similar rates to what we see in clinical trials, but this is what they were seeing. And their main issue though at that time was really around the VTE issue, where they saw a statistically significant increase in PE at the Tofa 10 versus the comparator group. So that was, and the rate there was, I think it was about 0.5 per 100, if I remember right. But again, it was enough to cause concern given its difference with the other exposure groups.
Yeah, I just found in your first paragraph of your letter in the annals that the 5BD was sort of triple the TNF rate for serious infections. So clearly that was a, now they say for fatal infections within 28 days and non-fatal serious infections, there was a tripling of the difference between TNFs and TOFA5. So clearly that's what raised concern. And maybe that's why you looked at this analysis. So you were saying you actually did a kind of 2-study situation. Can you fill us in on what happened?
Yeah, so, and that tripling was in that over age 65 group. And, you know, overall, the rates were much closer. There was a dose-dependent increase, but it was much, much closer.
It was over 65s. Okay.
Yeah, there wasn't a difference overall, but in that group that was 65, there was an increase, particularly at the 10 milligram dose. So the following study was hatched. You know, let's look at this issue with more granularity in all the clinical trial data collected to date. In absence of the study, you know, outside of this study. So that was done. And then the idea was also to look in the Corona RA registry about the same topic. You know, look at individuals that are starting these therapies, TOFA and, you know, other biologics, for example, and look at starters of both drugs and look at their infection rates in various age strata, particularly above age 65 and below age 65. So this was kind of 2 studies stuck together. In fact, the Corona, it was too much to publish in one paper as 2 full-length studies. So my thought was to make this a letter that was very focused to answer the question about age 65 and up. And basically the question is there effect modification due to age? You know, we know that everyone has higher rates of infection when they're over 65. It doesn't matter if they got RA or don't have RA or what drugs they're on. I mean, everyone, it's a risk factor. And so the question is it any different of a risk factor for TOFA users than it would be, you know, other drug users? So I thought we should publish this as a letter, very focused. And then we kind of threw on this, you know, the results of the Corona study is kind of contextual info and a discussion kind of like into to the letter. So that was kind of how it evolved.
Okay. So you had 2 groups. You had the Corona group, which was a few thousand patients, I assume. Just a small clarification. This analysis was of all phase 2, 3, 4 studies, which included a TNF inhibitor control or comparator arm. Just to make sure this is clear. Not all phase 2, 3, 4 studies, but those that included a TNF inhibitor comparator arm or control arm. What was the methodology? How did you go about doing it? Just straight from the...
Yeah, so when we went back, we looked at all phase 2, 3, and 4 data, and with the exception of the cardiovascular post-marketing study that's ongoing that we just discussed. So we took all the other data and you know, this included people on 5 milligrams and 10 milligrams. It included adalimumab and placebo comparators. And I think overall it was about, you know, 2,100 some patients, 2,200 patients. And most of them are under age 65, but about 15% of them are above age 65. So we had those comparison groups of 1,800, I have the paper here, 1,841 patients below that age threshold and 339 above. And then we simply calculated crude incidence rates for serious infections, you know, censoring people at the time of their first infection. And we did that for each exposure group. And then we stratified by age. And, you know, eventually we also just did a model, you know, looking at a Cox proportional hazard model that included a few things to adjust for, but mainly just looking at exposure group and age group in that model, and then exploring interaction terms between age and the exposure. So that is all presented in the article.
And the big numbers in the registry, you had over 10,000 patients to follow with a couple of thousand.
Yeah, the registry had 10,000 plus patients. You know, most of them were biologic DMARD starters, 8,300 plus, and I think about 2,000 TOFA starters. So, you know, a decent chunk of that was TOFA starters. So it was pretty nice to see.
So what did you find? What were the main findings of the study? And did the corona findings match the clinical trial findings pretty well?
Yeah. So, you know, I think as expected, as I said before, not surprisingly, the rates were higher. So in the clinical trial data, I'll speak to that first. The rates were higher, of course, and they're always higher in people age 65, no matter who they are. And the rates were higher for TOFA users, and they were higher for adalimumab users. They were higher, you know, across the board. So, you know, what did we see between low and high age groups? So when you looked at people under age 65, for example, the rates were, you know, between 2 or actually 1.48 and basically 2.35 per 100 patient years. So adalimumab was 1.48. TOFA 10 was actually 2.0, and TOFA 5 was in the middle, where it actually was the highest, was 2.35. Of course, all these confidence intervals overlap. They're all basically the same. And placebo was a little...
Yeah, we kind of expect 3 per 100 patient years, just having rheumatoid being on steroids and methotrexate. Yeah.
Right. So this is about, you know, this is what we've seen in clinical trials with all the JAKs and really most of the biologics as well, around that 3 per 100 range. Now, when you move to the strata, and I'm sorry, that was below the 65 age group. When you move to the above 65 group, you see the rates go up. So for TOFA 5, you go up from 2.35 to 4.55, so you almost double, which is about what you'd expect. From all the data, you usually kind of go up 1.5 or 2-fold in that older age group, no matter what the drug you're talking about. So TOFA 5 about doubled, TOFA 10 went from 2.0, and here's what's interesting, it went to 11.3. So that didn't double, that like 5-fold increased. So, you know, ding, 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 maybe there's effect modification going on with that dose. Adalimumab, almost doubled, 1.48 to, well, 2.44, almost double. But again, similar to the TOFA 5, you see a similar jump in risk. So what we see, Peter, in most, you know, in most studies, with, I would say almost all studies, the absolute risk goes up with age, but the hazard ratio, or the relative risk that's presented by the drug, when you compare a person on the drug with a person not on the drug, the relative risk largely stays similar the whole way. If it doubles the risk for a 35-year-old, it tends to double the risk for a 70-year-old. It's just the absolute risk is 2 or 3-fold times higher often.
I think the interesting comparison is against ADA, because we've got a feel for ADA over 20 years. Do you think there's a doubling of difference, or do you think the confidence intervals overlap and it's really 3 versus 3?
Yeah, so, I mean, clearly the confidence intervals overlap on all these things. So I can't say there's a statistical significant difference. But actually, when you looked at the modeling or the hazard ratio of, you know, when you look at an interaction, there was a statistically significant interaction with the TOFA 10 dose. Meaning when you compared the rates between older and younger, at each of those exposure groups. So, you know, TOFA 5, older versus younger, TOFA 10, older versus younger, and ADA, older versus younger. Like I said, TOFA and ADA, the older group goes up about 2-fold, or between 1.6 and 1.9-fold, but the TOFA group goes up 5.5-fold. That increase in relative risk was statistically significant. So it did appear to have a statistically significant interaction or effect modification due to age.
Okay, and apart from age, any clues for other response modifiers like background methotrexate, background steroids? Were the over 65s taking more steroids than the under 65s?
That's a great question. That was not included in the study. We did not model that, yeah. But that's possible. If there was differential steroid use between the groups, that could explain it.
And again, you didn't actually have a chance to look at any opportunist infections, because even though they're rare, they're the ones that often really worry us, because they put people in intensive care and things like that.
Yeah. You know, we have in other studies, and I would just say too, I mean, I doubt there's an imbalance in steroids and methotrexate, just because we've looked at all this data in the context of some of those outcomes you just mentioned before.
Yeah.
We just had never really stratified it based on age with such granular attention to that. But, you know, the level of steroid use seemed to be, you know, pretty similar between all exposure groups. But I think your point is good. You know, whether it was exactly balanced between older and younger, that's an open question. But, you know, in terms of zoster risk and OI risk, I mean, we've looked at, you know, age was certainly a risk factor for some of those infections in the modeling, you know, an independent risk factor. So when you control for differences in steroids and other things, you know, we do see it as an independent risk factor for pretty much all those infections.
Okay, so luckily we hardly ever use 10 milligrams BD, only a couple of countries in the world do, but the ulcerative colitis guys do. Would you give the gastros any advice about that dose? Induce remission and then cut it to 5 BD or something like that?
Yeah, I mean, I think, you know, I think that's probably the advice they've been given, or, you know, a lot of people got their patients off 10 around this time. But I think, you know, the way they're using it is just like you said, short term at 10 for 6 or 8 weeks or however long the induction period is, and then dropping it. And, you know, that also accounts for the ability to wean steroids during that time too. So there's a real benefit if 10 is, you know, better to get people off their steroids and get people into remission, then, you know, I think using 10 for a short time period and dropping to 5 seems very reasonable, even with this data. You know, it's not long-term 10 usage. So, and you're right. I mean, I think the nice thing about this analysis is that it does suggest there might be something different with the high dose. And so it does, I think, reinforce kind of all the decisions that were made years ago, that the benefit risk trade-off of 5 versus 10 really favored 5. And I think that's why that was the approved dose in most places. So.
That was an interesting thing you just mentioned over time. It may not be possible. Were you able to tell if the risk, like bacterial infection with TNFs, is in that first 6-12 months? Is the infection sort of happen at any time over time, or is it early and then not a risk after that?
Yeah. It's funny, we were just talking about that in another meeting today. It kind of depends on the infection. If you look at serious infections, you do see something similar. I mean, you do see an increase early on, and then it levels off and drops. Now, I don't know if that's a consequence of just, you know, of just this being clinical trial data. I mean, that is what you see in clinical trial data, right? Yeah. People stop the drug when they get their big infection, or, you know, you kind of see the survival of the fittest or depletion of susceptibles over time. So rates decrease just in clinical trial data due to the construct of the trials. But in real world data, you know, I don't think I've actually seen that modeled. I mean, there's not a lot of real world data with JAKs. There is with Tofa, but I haven't necessarily seen anyone look at specific windows, you know, of risk in the first 60 days or first 90 days. I can tell you with zoster, I mean, we did it initially, and we did see an increase, a little bit increased risk in the first 90 days. But to be honest, it's pretty level throughout. Like, it kind of never really goes up or down. It just kind of, that slope of that curve was always pretty stable. So I think there's probably some of that similar to what we've seen in TNF blockers, but it hasn't been explored to the same extent, I think, in real world data.
All right. Well, thank you very much for a very informative letter. What would you suggest to the clinician to take home? 10 for short period only, and you expect an increased risk with age, and to work on steroids and other background drugs as a way of mitigating risk.
Yeah, I think, like I said, just with the GIs, you know, it's 10 for a short period. It allows you to get off steroids, and you drop to 5. I think, you know, to me, you know, this over age 65. So after this happened, you know, we've been doing this with all sorts of program data. We just presented the Berry data at ACR. You know, we've looked at some other data. I mean, like I said, I'm still of the belief that Tofa 5 is really no different in someone who's over 65 than any of the other drugs. Tofa 10 does appear to be different. to me, according to this analysis. So, I think, the risk elevation that you see in elderly, again, is across the board. The absolute risk go up, but the hazard, the relative risk with each drug, no matter what you're talking about, tends to stay the same as compared to a younger person. So I guess my thought is that I thought the European Regulatory Agency was a little unfair in the way they verbalized that recommendation or their concern, because it really should have been more specific to Tofa-10.
Yeah, so it sounds like they overreacted, but they made life very difficult in Europe for JAK users, and often it sort of taints the whole class,
Yeah.
Okay, so thank you so much for your time today, Kevin. It's been the CSF Author Interview podcast. If you'd like to know more about this paper and others uploaded to the CSF website this month, you can get detailed slide sets are available in the publication section at cytokinesignalingwith2ls.com. Please subscribe to the podcast on iTunes or wherever you get your podcast from, and give us some feedback and let us know what you think. So thank you so much, Kevin, for your time.
Thanks, Peter. Great to see you. I'm hoping for another gold medal.
All the best.